All right. Good afternoon, everyone, and welcome to today's webinar. It takes a village of care professionals to increase access to reproductive health care and improve maternal health outcomes. Presented by the Network for Public Health Law. My name is Daniel Wacker, and I'm the Program Development Associate here at the network. I'm here to just remind you guys that we do have both the chat and the Q&A function available for today's webinar. Please use the chat for discussions and the Q&A function to ask questions for the panelists at the end. We will be doing a question answer session at the end, so don't worry, we will get to your questions. Also be noted that a recording of the webinar as well as the slides will be available in about a week on the network's website, and you all be receiving an email when those are available. With that, I'm going to pass it over to our moderator, Kathy Hoke, who is the director of the network's Eastern region. Kathy?
Thank you, Daniel, and welcome everyone to the Network for Public Health Law's webinar. It takes a village of care professionals to increase access to reproductive health care and improve maternal health outcomes. I have the pleasure of the easy job here, and that is moderating a panel of terrific presenters. I'm going to set the stage first with a little bit of data, and then we will hear from Haley Garcia, and she's going to talk about laws regulating direct entry midwives. Haley is a soon-to-be graduate, and I mean really soon-to-be graduate, of the University of Kentucky College of Law. Prior to law school, she attended the George Washington University School of Public Health, and she's been working with the network's health equity team since her first year in law school, because once we get a good one, we keep them. Haley focused much of her effort with the team on the role of law and policy in improving health outcomes for pregnant people with a focus on health equity. Next, we will hear from Jordan Jekyll, also a soon-to-be graduate, this one from my alma mater and current teaching home, the University of Maryland Carey School of Law. Jordan is a student attorney in the public health law clinic that I direct, and she is the editor-in-chief of the Journal of Healthcare Law and Policy. Her article on medication abortion access was published by the Food and Drug Law Journal. She is, her focus of her work in the public health law clinic has been on maternal health, reproductive health care access, health law and policy, and anything else I asked her to do during the semester, and always got a yes. And then we'll be joined by co-panelists, Dr. Jessica Lee and Dr. Mary Jo Bondi. These are colleagues of mine from the University of Maryland, Baltimore. Dr. Jessica Lee is an assistant professor in obstetrics and gynecology at the School of Medicine here at the University of Maryland. She received her Doctor of Medicine degree from the University of Pittsburgh School of Medicine and completed her residency in Pittsburgh as well. I'd like to know if she's a Ravens or Steelers fan, but we'll leave that for another day. She did a family planning fellowship at the Johns Hopkins School of Medicine, which must have brought her to Baltimore. She earned her Master's of Public Health degree likewise from Hopkins Bloomberg School of Public Health. She currently directs the Ryan Training Program at the University of Maryland and works to provide comprehensive residency training in contraception, pregnancy options counseling, and abortion techniques. Her areas of research and clinical interest involve pain management during gynecological procedures, emergency contraception, and contraceptive counseling. With Dr. Bondi, she will be leading efforts to implement parts of Maryland's abortion care clinical training program that they will tell us a lot about. And then Dr. Mary Jo Bondi is the program director for the Doctor of Medical Science program at the Graduate School at the University of Maryland, Baltimore. This is the first clinical doctoral program specifically for physician assistants in Maryland. Dr. Bondi graduated from Marquette University as a medical technologist, and after becoming a PA in 1993, when she was 12 years old, she worked in orthopedic surgery, internal medicine, and emergency care over the years. In 2020, she became the first physician assistant to serve as the CEO of the Physician Assistant Education Association, where she led a staff of 40 in serving the more than 250 member programs in the organization. Dr. Bondi's involvement and contribution on key publications related to healthcare workforce shortages in Maryland contributed to UMB Graduate School receiving significant state funding to establish a physician assistant leadership and learning academy to increase the capacity of faculty to educate future PAs. hopefully, to stay and work in Maryland. With Dr. Lee, Dr. Bondi will be leading the effort to implement parts of Maryland's abortion care clinical training program. So I'm sure that lets you know the quality of the folks you're about to hear from. And so excuse that you have to hear from me for a couple of minutes with a little bit of data. But I wanted to share just a couple of ground setting definitions and information. So when we talk about maternal mortality, what we mean is when a person dies due to pregnancy-related complications or pre-existing conditions that are exacerbated by pregnancy. Some people consider the time frame within which we consider maternal mortality, or some organizations, as short as 42 days. I think the current standard that we see more often is looking at a full year postpartum, gives us a much better picture of what really is the maternal mortality rate. And what the maternal mortality rate is, just so that if you're not math people like me, it's the rate of deaths of pregnant people per live births, typically expressed each year. Oops, I did not mean to change that. Sorry. There you go. My slide was not advancing. And then maternal mortality in the US, you're going to hear from Haley some data about where our maternal mortality rate is. But I want you to frame it to think about it is during pregnancy, during labor, or within that first week of postpartum, and then 1 year postpartum. And you can see it is pretty much evenly split, with a third of the deaths taking place, kind of the trimesters, frankly, of maternal mortality in the United States. And then I do just also want to touch on, we talk a lot about maternal mortality, but maternal morbidity is also a concern. And that is really any health condition that's attributed to or aggravated by pregnancy and childbirth that leads to negative health outcomes, a diversion from good health. And just to situate in your minds, when folks are talking about why it's so important to have, access to midwives, to doulas, to expanding care through PAs and NPs, primary care physicians, that the factors that increase maternal morbidity are pre-existing mental health conditions. My folks with the Harm Reduction Legal Project at the network focus a lot on examining substance use during and post-pregnancy as one of the contributing factors to maternal morbidity and mortality, but also the lack of access to reproductive health care. That leads to poor health outcomes. Previous trauma, stress during the prenatal period, and of course, the big one that we really need to address as a society is provider bias or discrimination that we know has a particularly negative impact on people of color in our communities. So with that note, I am going to stop my share and allow Haley to pull up her slides, and she will talk to you about her work in examining the various state laws around the country related to direct entry midwives. Take it away, Haley.
Thank you, Kathy. Can you hear me? Okay. All right. So yes, like Kathy said, I'm going to be talking a little bit about direct entry midwives across the nation. Specifically, we'll be looking at a few different examples of the laws in the 50 states. But first, before we talk specifically about direct entry midwives, I wanted to expand a little bit on the data piece that Kathy was talking about. So here's a chart I've pulled from the Centers for Disease Control and Prevention. It's their provisional maternal mortality rates. And these are presented as a rate, like Kathy explained, and that it would be death per 100,000 live births. So I think what is most concerning is, one, how high our death rates are, right, in the United States. And then also we see this trend that they are increasing. You see a big spike between January 2021 and January 2023, but still September 2023 is higher than we were in January 2019. So things really aren't getting any better. And then if you add to that the differences and the vast disparities we have in maternal mortality rates by race and ethnicity, you can see there's a huge difference. So in this figure, the orange line is the deaths per 100,000 live births for American Indians, Alaskan Natives, and the purple line is Black individuals who are not Hispanic. So you can see for those groups in particular, there is a vast disparity in the maternal mortality rate between those two groups. So the United States, unfortunately, also has one of the highest maternal mortality rates of what was termed high-income countries. In 2021, according to the CDC, the rate per 100,000 live births in the United States was 32.9, which is really high, especially when we contrast that with the Netherlands, which had 1.2 deaths per 100,000 live births. Canada, who is close to us, 8.4 deaths per 100,000 live births. And then the United Kingdom, which had only 6.5 deaths per 100,000 live births. So the United States, the rate in the United States is just multiples of what it is in other high-income countries. Part of the problem is this shortage of maternal care providers. The United States generally has a shortage of maternal care providers, that is both midwives and OBGYNs. But there's also this vast disparity in the number of midwives in the United States compared to the number of OBGYNs who attend live births. The World Health Organization has said the use of midwives as part of the maternal care team is an evidence-based way to reduce maternal mortality rates. So here you can see in the United States, we have about 4 midwives and 11 OBGYNs per 1,000 live births. Contrast that with the United Kingdom, who has 43 midwives and 11 OBGYNs per 1,000 live births. So there's already just an increase in the number of providers, and most of that difference is made up in midwives. So the resource I had in the network and what I want to talk to you about today is direct entry midwives as part of a solution to this maternal mortality problem and the shortage of maternal care providers in the United States. So direct entry midwives specifically are midwives who are credentialed to provide childbirth support and maternity care services without going to nursing school and obtaining a formal nursing education. A majority of states do require a license to practice as a direct entry midwife. There are 13 states that don't regulate direct entry midwives at all, and that is Connecticut, Georgia, Iowa, Kansas, Massachusetts, Mississippi, Nebraska, Nevada, North Carolina, North Dakota, Ohio, Pennsylvania, and West Virginia. So in those states, they don't speak on direct entry midwives at all. And then in the state of Missouri, you can practice as a direct entry midwife, but they do not require a licensure. So again, a majority of states do regulate and require licenses for direct entry midwives. They're regulated by state licensing boards who are responsible for setting training and education requirements for licensure. And then they also prescribe guidelines for the administration of medication by direct entry midwives and the specific services that they are allowed to provide. So before I talk about specific state laws, I did just want to provide some commonly used terms in the laws regulating direct entry midwives, and terms I'm just going to be using in general when I speak about them. So the first is the Midwifery Education and Accreditation Council. This is an organization whose purpose it is to establish standards for the education of competent midwives. This includes the providing accreditation to schools of midwifery. Then we have the North American Registry of Midwives, which is an organization which sets the standard for the provision of the Certified Professional Midwife credential. And they also provide those certificates to applicants. And then we have a bridge certificate, which is it's offered by the North American Registry of Midwives, but it only requires 50 accredited approved continuing education contact hours. It's different than a certified professional midwife credential because the educational requirements are less. A BRID certificate can kind of be on the way to getting a CPM credential, but it's not the exact same thing. So I've pulled out examples of a few different states just so you can kind of see the variance in the different ways that states have chosen to regulate direct entry midwives. So Alabama first. So in Alabama, in order to practice as a direct entry midwife, you must obtain a certified professional midwife credential through a program or pathway accredited by the MEAC, which is the Midwifery Education Accreditation Council. They have a few different schools who have obtained accreditation, and you can find a list of those on the MEAC website. In Alabama, the licensure of direct entry midwives are regulated by the Alabama State Board of Midwifery. So they have the responsibility of prescribing guidelines, educational requirements, etc. And then in Alabama, direct entry midwives can administer anti-hemorrhagic medication and oxygen, but only in emergency circumstances. Arkansas is up next. In Arkansas, in order to practice as a direct entry midwife, you must obtain the Certified Professional Midwife certification from the NARM or hold an equivalent certification. And by equivalent certification, they mean other certifications that are specifically laid out by the Arkansas Department of Health, and those are listed within the regulations. In Arkansas, direct entry midwives are able to provide eye prophylaxis and oral vitamin K. But I included Arkansas specifically because they are only allowed to administer medication acting as the agent of the client. So it's different than just having a blanket permission to administer medications. They kind of have to act on behalf of the client in order to provide the medication rather than acting as a medical professional. So then Hawaii. So to practice as a direct entry midwife in Hawaii, you must hold a certification as a certified professional midwife and complete a formal midwifery education program that is accredited by the MEAC, or you can obtain one of the BRID certificates from the NARM. Interestingly about Hawaii and why I wanted to include them specifically, their statute explicitly exempts traditional healers from these education requirements. So if you are a traditional Hawaiian healer, you are able to practice as a direct entry midwife without needing to obtain these educational requirements. In Hawaii, direct entry midwives are regulated by the Department of Commerce and Affairs, professional vocational licensing, and the Board of Nursing. And then in Hawaii, direct entry midwives can purchase and administer non-controlled legend drugs and devices. And so as part of the formulary in Hawaii, direct entry midwives are able to purchase and administer ophthalmic prophylaxis, vitamin K, epinephrine for neonatal resuscitation, oxygen prophylaxis for group B streptococcus infections for mothers, and then postpartum anti-hemorrhagics if indicated. They can also administer RHO immune globulin epinephrine for an allergic reaction, and then give fluids and local anesthetic. And that list is a pretty common formulary for what direct entry midwives are allowed to administer, if they're allowed to administer drugs at all. So I included New Hampshire because they lay out some different educational requirements. So in order to practice as a direct entry midwife in New Hampshire, you must have completed high school or its equivalent. And then you are also required to complete a college level course in anatomy and physiology. They have some practical experience requirements. And then they also require completion of a credential course in birth related laceration repairs, as well as obtain a current certification from the North American Registry of Midwives. And then they also require a written and oral exam. And I should mention at this point, although I haven't listed it on the slides, commonly in all of the states that license direct entry midwives, it's also an educational requirement to have a up-to-date certification in adult and pediatric and neonatal CPR. So that's kind of just common across all the states, so I didn't include that here, but I feel like I should at least mention it. The regulating body in New Hampshire for direct entry midwives is the New Hampshire Midwifery Council. And then in New Hampshire, direct entry midwives may obtain, possess, and administer a specific list of drugs. Again, it's very similar to the list I laid out in Hawaii, but they have an additional statement in the statute that direct entry midwives may administer any other drugs which are prescribed by a physician that are consistent with the scope of midwifery practice. All right, and finally, I've included Virginia. So again, the educational requirements are very similar. A current certification as a certified professional midwife. And then they also must provide a report from the North American Register of Midwives, which indicates whether or not there's been an adverse action taken against the applicant. The regulating body is the Virginia Board of Medicine, but they have also an advisory board on midwifery that's part of the Board of Medicine. And then in Virginia, direct entry midwives cannot administer medication at all. So finally, I just wanted to talk a little bit about the barriers to entry for direct entry midwives. So we know the maternal mortality rate in the United States is very high and that we have a provider shortage, and that direct entry midwives are a way to get at that shortage in a way that may be more equitable. However, there's still many barriers to entry and to obtaining a license as a direct entry midwife. One is cost. I took a look at some of the different midwifery programs that were listed on the MEAC website, and they're very expensive. One in particular is a 3-year program, and it costs $27,000. The tuition is $27,000. Now, compared to a nursing degree that may not seem like a lot of money, however, it's also important to note that these programs often are not eligible for FAFSA or federal funding. So you can't use, Pell Grants or federal loans to pay for them. Then there's also a significant time requirement that's required to obtain a license. You have 3 years of education, then you have an application process. In some states, you have to take an additional exam. So those are all time requirements, not to mention additional costs, because states vary on their licensing fees. So that's just another barrier to entry because of cost. And then you have compensation. So providing these services costs money. In some states, I think the average compensation for a certified professional midwife is around $50,000 a year. That was in Florida specifically. So you have a significant investment in both cost and time and not extremely high compensation. And then finally, there are differences in insurance coverage. So in some states, Medicaid does reimburse direct entry midwives. And in some states, they only reimburse for certified nurse midwives. So there's a difference in states whether or not Medicaid is going to cover their care. So that's really all I have for you today. Thank you for listening, and I'm going to pass it off to Jordan.
Thank you, Haley.
Let me get my slides up. All right, so hi everyone. My name is Jordan Jekyll, and I'm currently a third-year law student at the University of Maryland. As Kathy said previously, I'm also a student attorney in the Public Health Law Clinic, and I'm going to be going over a 50-state survey of doula care. Essentially, I want to highlight how doula care can help address the extremely high maternal mortality rate in the United States, address the current state of doula care coverage and certification in our country, and propose various policy solutions that states can take to increase doula participation, access, and affordability. The information that I have for you is based on a project I completed over the past few months. I went through state by state looking at regulations and statutes that cover doula care, coverage, and certification to get an understanding about the current state of access and develop ideas for improvement. And the chart that I created, as well as an accompanying policy brief, are going to be available through the network later on for those who are interested. So just as a brief overview, first I'll be going over a background of doula services, why doula care is important, and the meaning of culturally competent care. Then I'll dive into an overview of the current status of doula laws and regulations, summarizing the results of the 50-state survey I completed. Finally, I'm going to go over various policy recommendations for the expansion of doula care access, awareness, and affordability. So let's start with what exactly is a doula. As defined by DONA International, which is the largest certifying doula organization in the United States, a doula is a trained professional who provides continuous physical, emotional, and informational support to their client before, during, and after childbirth to help them achieve the healthiest and most satisfying experience possible. It's important to note that doulas provide care that is non-medical. So while they are involved in the birth and the pregnancy, they're doing more support tasks, which might look like advocacy for the birth preferences of the birthing individual, helping prepare for delivery, and sticking by the birthing individual's side throughout labor. There's also other postpartum care that's provided, which might range from light housekeeping to wellness support. Many doulas are also trained to provide their clients with culturally competent care. And cultural competency is the ability of a provider and organization to effectively deliver services meeting the social, cultural, and linguistic needs of the client. Some key components of this care would include recognition of the differences between the self and the patient, language accessibility, effective cross-cultural communication, and understanding. Essentially, cultural competent care is care that reflects the unique needs and lived experiences of the patient within that specific community. And it's really important because culturally competent care can increase patient safety and satisfaction while decreasing inefficiencies, disparities in care, and cost. And then when we're talking about doulas, another important distinction to make is the different classifications of doulas, both in practice and in statute. So there's community-based doulas, which is typically a community member who's specializing in culturally sensitive care, addressing discrimination and meeting language gaps. And these types of doulas will best relate to their clients and improve health equity. And then there's also the statutory term, which is a state-certified doula, which is any doula who receives certification through a state statutory or regulatory scheme. And a lot of times they use this classification either as a special title or as a requirement for Medicaid reimbursement enrollment through the state. So it's also important to understand why doula care is important when we're looking at the overall high rates of maternal mortality and morbidity in the United States. So first, doulas can provide care that is more robust and focused on the maternal aspect rather than just the infant, particularly during the postpartum period, because doulas are a designated care provider for the birthing individual rather than just for the infant. And that gives a more holistic care to that person. It's also true that a patient who receives doula care is going to experience markedly increased physical and mental health outcomes. So, for example, doulas are associated with alleviated anxiety and depression. Doula patients are also less likely to need a C-section, which can lead to less costly and less invasive births for the birthing person. And doulas are more likely to provide culturally competent care based on their role, training, and purpose. Doula care is also known to reduce the impacts of racism and racial bias in healthcare for pregnant people of color. And then doulas also can provide greater support during labor and delivery. It's estimated that nurses only spend about 10% of their time supporting the birthing individual, whereas doulas are filling in the gap and providing constant support. Finally, doula patients experience greater autonomy and confidence in their birth plan and in getting their needs and preferences met. So we can see from this list that this is increasing both systemic outcomes and individual outcomes for those involved in the birthing process. Now that we have an understanding of what doula care is, I'm going to talk more about the current landscape as far as statutes and regulations that govern doula care coverage and certification. There are also some informal agency actions that govern in this area, but for the purposes of the survey, we just focused on codified statutes and regulations that are more formal and fixed. It's also important to note that there is a number of states, upwards of 25, that currently have no laws or regulations on the book as far as addressing doula care coverage in any way. So this is just from the sample of states that do have those laws already implemented. The first area to look at as far as doula regulation goes is certification. So unlike for others that are involved in the birthing process, like a doctor or a nurse, there's no formal certification or licensing requirement for a doula. But it is really common for doulas to receive certification from a certifying organization. And so when we're talking about certification within the doula space, there's that general certification and there's statutory or regulatory certification. So the traditional pathway is to go to a certifying organization and complete their program, and then you become a certified doula, and that's typically a non-governmental entity. Now, as states have started to regulate in this space, there's the first statutory pathway to doula certification, which is to receive the title of a state certified doula. An example of this is in Virginia, where the state will give you the state certified doula title if you complete certification from the State Board of Health approved organization. The second statutory pathway is going to be to get certified to be eligible on the Medicaid reimbursement registry for that state. So an example of this is in New York, if you get the state certified doula title, you are going to be getting placed on the state doula directory for Medicaid reimbursement. Really, the requirements vary state by state, but generally they're about the same depending on what the purpose of certification is. And some common requirements for certification would be paying fees, completing educational and training requirements, and getting certification from a state-approved or nationally recognized organization. So that leads us into our next area of regulation of doulas, which is training and eligibility. So states impose a number of different training requirements on doulas who want to be certified. Some of the common ones include completing training from a doula certification organization, getting instruction in core competencies, observing live births, serving as a doula during a live birth, and completing first aid and CPR training. There's also at least 5 states that specifically tell you what type of content must be included in those trainings, which might be anything from standards of practice and ethics, to postpartum care and grief, to communication skills, community resource referrals, and self-care. And we can see in those topics that are carved out in those states that they're really trying to directly attack the maternal mortality causes in their states. And it's intentional in making sure that doulas are really prepared to attack those issues. There's also some certification pathways in certain states that allow for alternative training requirements for community-based doulas specifically. For example, in Arizona, they allow for an alternative training route if you're a doula who received community training in non-Western doula practices. There's also a number of eligibility requirements for doulas. Commonly, you must be at least 18 years old. You must have at least a high school diploma or equivalent. You have to sign a code of ethics, pass a background check or fingerprint clearance, provide references or recommendations from previous clients or those who have watched you act as a doula, and where applicable, enrolling in the Medicaid provider registry. So that brings us to our next topic, which is Medicaid coverage and reimbursement. So currently, most Americans are required to pay for doula care out of pocket if it's something they'd like to receive, as most private and public insurers are not covering doula services. That can be quite a burden because doula costs range from about $500 to $3,500, depending on what services are provided and the doula's level of experience. Medicaid coverage is a really great way to decrease this barrier because about 45% of all births that take place in the United States are covered by Medicaid. So this can help improve maternal health outcomes and equity. Currently, there are 20 states that are offering some form of Medicaid coverage for doula services, but the success of these programs has been hindered by the low reimbursement rates that the states offering doula reimbursement under their Medicaid program provide. So we're seeing a lot of variation in these states between the level of coverage, the reimbursement rate offered, and the enrollment requirements, which all can create hurdles to actually getting doulas on the registry. The rates are also rarely codified, meaning that the state agencies are given pretty great discretion to change the rates, and that the information to even find the rates can be really hard. So that might make it more difficult for doula as well to do that cost benefit analysis about whether what they'll get paid to enroll is worth the hurdles. There are two outliers to this, which are Maryland and Minnesota, and they really demonstrate the vast difference between the rates that the states are paying doulas through Medicaid reimbursement. So Maryland is offering up to $494 for doula coverage, with $350 of that coming as a flat rate for labor and delivery. Whereas contrastly, Minnesota has a codified rate as of 2024 of $100 per prenatal and postpartum visit and $1,400 per each labor and delivery. So you can see there's a really big disparity there. We have seen with early implementer states such as Oregon and Maine that low reimbursement rates stunt progress. And so both of those programs recently raised up their reimbursement rate to be about $1,500 per pregnancy. And already those rates are starting to drive higher doula registration in the states. The last area to look at as far as a regulatory background is doula advisory boards and maternal mortality review committees. A lot of states have started implementing doula advisory boards or committees that are tasked with advising state governments on doula policies. And often these committees are really key in initiating and shaping the certification and reimbursement processes within their state. Many of the boards are also requiring that at least one member who is a doula participates. Tennessee takes it a step further, and they require the board to have 2 community-based doulas with experience serving Medicaid recipients and communities with high maternal mortality rates to be part of their committee as well. There's also a lot of these entities that are specifically looking to fix health equity, culturally competent care, and the Black maternal mortality rate. For example, in New Jersey, they've established a maternal care quality collaborative that works with the governor's office to specifically reduce the maternal mortality and morbidity rates and racial and ethnic disparities, with at least one member who's an expert in doula services. And then we have some states that are starting to mandate a doula as a member on their maternal mortality review committee, which is a previously established committee that reviews all maternal mortality instances in the state, but that is less common right now. So now that I've given everyone a little bit of a background as far as where we stand as a country, as far as maternal mortality and doula care is situated, I'm going to go through some different solutions that we could try to implement and that states could put into place to increase doula care and coverage. So the first overall theme for a sort of policy solution would be to improve doula coverage through greater affordability and accessibility. And the first action that states could take is increase reimbursement rates for doula services covered under the state Medicaid program. So currently, reimbursement rates, like I said, are often set too low to make it feasible for a doula to want to enroll and participate as a provider. And the lack of enrolled doulas severely limits the potential positive impact of these policies, because if there's not enough doulas registered that are providing Medicaid covered care, then those Medicaid recipients can't actually get access to the doulas. What's really needed is states to get a market rate and really value doula services at the level that they should be being paid at a market value. It's really important to get more doulas into the Medicaid programs so they can provide greater access to doula care. The next potential step is to increase affordability and accessibility is to remove hurdles to enrollment within the programs. Enrolling in Medicaid can take a lot of time and energy and expenses. And while doctors and physicians who are typically working in an organized practice might have the support to do so, doulas are often solo practitioners and they don't have the administrative setup to process the billing and insurance requirements. And then cost is another primary hurdle, because typically to register with a doula training and certification program, it's going to range from $800 to $1,200. And then on top of that, almost every state requires an additional $100 to $300 fee as part of the registration to get certified. More states should really follow New York's lead, where they have a rule of certification is required. They do not require a registration fee. States should also seek to fund and subsidize the cost of these trainings and certifications to increase the doula workforce. They could do this through grant programs or need-based funding that offsets the cost. An example of this is in Ohio, where they're waiving the certification and renewal fees for doula certification applicants with any family income below 200% of the federal poverty line. Another policy to consider is requiring all insurers, both public and private, to cover doula services. This is currently being done in just 2 states, which are Rhode Island and Louisiana. Rhode Island started their program of requiring all insurers in the state to cover doula services in mid-2022, and Louisiana followed suit just starting this year in 2024. We don't have the data yet to see if this really has had as big an impact as expected on the use of doulas, access to doulas, and the maternal mortality rate within those states, but this does seem like the best way to potentially really provide doula care to everyone, not just those who are on state-funded Medicaid. And it is definitely more of a hurdle and a more challenging policy to implement, but it is really exciting to see some states moving towards this. Some other suggestions for increasing affordability and accessibility would be to lengthen the statutory postpartum period so that doula services are covered for a longer period of time, to create more alternative certification pathways to increase the number of community-based doulas and expand the doula workforce across states, and to provide greater doula access to those in correctional facilities who are incarcerated and giving birth. The next policy solution is to increase the inclusion of culturally competent doula training and services. As I talked about earlier, culturally competent care has a real potential impact on the maternal mortality rate, specifically the Black maternal mortality rate. And so this care should be a mandatory part of all state certification. There are a lot of states that will optionally have cultural competency as a training or more broadly suggesting it should be used, but it really should be more clear-cut. Washington State provides a strong model for this. Right now, they explicitly require any doula who seeks certification in the state to complete cultural congruency and ancestral practice training and education. The final solution here is to increase awareness about doula care more broadly. One way to do this is by increasing doula participation as members of state maternal mortality review committees, or MMRCs. As I previously said, a lot of states are doing this through a specific doula advisory committee, but actually having states have a doula on the MMRCs, which are already established, is going to be another effective way to increase awareness about what doulas do and how they can help. MMRCs are specifically tasked with investigating pregnancy-associated deaths, reporting out on outcomes, and providing recommendations to the state on how to address these outcomes. Currently, every state in the District of Columbia, except Idaho, have formal established MMRCs. So since these states already have these committees in place, mandating that a doula member join is going to be a low cost and low administrative burden option that can greatly increase awareness about a doula's role in care and in health equity. And if there's community-based doulas that are required to join, this can also give needed insight on how to best address the high maternal mortality rate for some historically underrepresented communities. Another suggestion in this space is to educate the public and professionals about the role of doulas. Community outreach, particularly in those communities with higher maternal mortality rates, may help facilitate greater usage of doula services, as some may not know about the benefits. Further, educating medical professionals about the role and benefits of doula care and the ways that doulas can be included within care teams, particularly during labor and delivery, can really encourage these professionals to more frequently recommend doula services. The final suggestion is to overall improve understanding of racial disparities in maternal health outcomes. Given that there's vast discrepancies in the maternal mortality rate for Black women, as Haley previously touched on, further developing an understanding of how to improve health equity across all communities is really important. There's some states that are trying to take this action and using doulas as a means to do so. For example, California is requiring all health insurers to develop a maternal and infant health equity program that specifically addresses racial health disparities in maternal and infant health outcomes through the use of doulas. And that's going to start on January 1st, 2025. Having more states put in the investment and the time into understanding the needs of these underrepresented and historically silenced communities is really key to making sure doula care can be as effective as possible at decreasing our maternal mortality and morbidity rates. That is all I have. Thank you all so much for listening, and happy to take questions at the end of our presentation.
Thank you, Jordan. I want to acknowledge while the slides for Drs. Lee and Bondi are getting put up that there's been a lot of activity in the chat and in the Q&A, so keep it coming. Take it away, colleagues.
Let me just do this. All right. Well, thank you very much. Thank you for the opportunity to address this body. Thank you, Haley and Jordan, for really setting the stage for this conversation. Dr. Lee and I are going to discuss the work that's being done in Maryland to create a safe harbor for reproductive health. Dr. Lee?
So as you all know, the landscape of abortion legislation continues to change daily in the United States. And Dr. Bondi did a great job updating this as of very recently. We know that this map changes day to day, with the most dark red colors being the most restrictive states for abortion in the United States, and those being the lighter, cooler colors, the more protective. And I can draw your attention to where Dr. Bondi and I practice, which is very protective state of Maryland in teal. You may have all heard of the recent news with the Florida state abortion restriction, as well as Arizona's state abortion ban. So states continue to make headlines every day.
So one of the things that we realize is that research needs to inform policy. And one of the things that we have leaned into here in Maryland is the decades of research that show that physician assistants, nurse practitioners, certified nurse midwives can provide safe and effective abortion care, whether that be medical abortion or procedural abortion. That data shows that there are no differences in outcomes when they are trained as compared to our physician colleagues. And so complications as well are the same across the board when education and practice are available related to medical abortion or procedural abortion. We also recognize that PAs, nurse practitioners, certified nurse midwives can improve access and diversity as we work to meet the needs of rural, urban, and marginalized groups, particularly who are adversely affected with maternal and fetal morbidity and mortality. In Maryland, we know that there is significant need. Based on Guttmacher data, over 2/3, or approximately 63% of our counties in Maryland do not have access to an abortion clinic. So we know that there's significant disparities of access, and we know that that is contributing to maternal morbidity and mortality. We also know that as Haley and Kathleen have presented, that there is significant disproportionate underrepresented maternal and morbidity mortality. And so decreased abortion care access disproportionately impacts underrepresented populations, increasing health equity or health inequity, excuse me. There are states currently where advanced practice clinicians can provide abortion. In this map, you will see that there are states that are in the orange that can provide procedural and medication abortion. There are 2 states where medication only may be provided by advanced practice providers, and that we see an increasing number of states where advanced practice providers are unable to provide this care. So in Maryland, we are fortunate that in 2022, early in the legislative session of 2022, Maryland passed the Maryland Abortion Care Access, giving the nurse practitioners, physician assistants, certified nurse midwives the ability to provide access to abortion as well as advanced contraceptive care. Previous to that, Maryland was considered a physician-only state. Then we know in June 2022, Dobbs versus Jackson, the Women's Health Organization, the Supreme Court changed 50 years of precedent, overturning the protection of women's right to abortion and leaving that up to the states. At the time when the legislation was passed in Maryland in 2022, the legislation included funding for training. However, that was withheld until January 19th, one day after Governor Moore was sworn in, where he released access to training funding for nurse practitioners, physician assistants, certified nurse midwives, and other physicians to learn more about abortion and advanced contraceptive training. So the other thing that we saw post-Dobbs was there was a significant increase in the number of abortions that were being performed in Maryland. We basically attribute this to the shifting landscape, the shifting legislative landscape with states surrounding us, which noted that more women were traveling to Maryland to receive abortion services. I will tell you that this map actually only shows procedural abortion and is not including medical abortion. We saw a rapid rise in December of 2022.
So I'll speak a little bit about what abortion training has looked like in America, as well as the impact of Dobbs. I myself direct the abortion training program for our resident physicians and our medical students here at the University of Maryland. But just know that pre-Dobbs, there were many OB/GYN programs in the United States. You can see all of them in diamond shape across the country. And in general, 45% of these OB/GYN programs now exist in abortion prohibitive states. Because of Dobbs, 14% have lost in-state abortion training options. And we've noticed this has a huge impact in how our medical students apply to residency even. They don't want to be in a residency program that doesn't have access to this training. We're seeing with a 10% decrease in applicants to abortion prohibitive states. So this is going to impact the future workforce in terms of physician abortion training for sure. Next slide. And then we talk about other specialties. I want to recognize that so many other specialties can participate and do participate in abortion care. That's emergency medicine, internal medicine, family medicine, pediatrics. A lot of studies have noted physicians in these fields really desire to provide care for patients seeking abortion. We consider it part of comprehensive essential health care. Similar to the OB/GYN residency trends, we've also seen changes in overall residency applications in the past cycle for those going to abortion prohibitive states. You can imagine that even if they're not going into the field of OB/GYN, they may not want to practice in a state that doesn't allow for full spectrum essential health care. They may not want their loved ones to be going to that state. So there's a lot of things to think about as we think about reducing maternal morbidity and mortality, and that pregnant people may need services other than just OB/GYN care. They're going to have a cardiologist to go to if we're seeing less and less doctors wanting to go to those states, period. We also recognize that training can be impacted by non-OB/GYN residents. So go back a slide for me, Dr. Bondi, sorry. We know that sometimes OB/GYN residents travel to get the care they need, and it's been hard for us to balance what kind of residents we address with our training programs, since I get so many requests from out of state. So then it becomes kind of a battle for who gets the spot. And it's hard to prioritize whether it's an emergency medicine doc or should it be a out of state OB/GYN residents. So it's a challenging time for training. Next slide. And then not to forget, medical students very much desire to learn about abortion and complex contraception as a part of their medical school education. Medical students are a huge backbone to eventually the physician workforce, and over 10,000 students matriculated into schools where abortion is banned or likely to be in 2021. And it's hard to know exactly the numbers that are directly affected by the ban, but it's a significant amount. And then we know that the exposure begins soon. I have a medical student rotation that's very, very popular. That's called a family planning rotation in our hospital-based abortion clinic. But it's clinically challenging to provide a ton of experience, even in our abortion progressive state. So how do we get these medical students interested and training already in abortion? Next slide. And
So we know, go ahead.
I'll hand it back to you, MJ.
Thanks. So we know some current abortion trends. We know that approximately 93% of abortions are conducted within the first 6 weeks of pregnancy. And we know that the trend is that greater than 50% of abortions are medical interventions. This is increasingly the preferred method of patients, where patients take 2 medications and the pregnancy termination happens in the privacy of their home. Training to competence using vacuum extraction techniques, we know takes time, takes clinical experience, and to gain competence and proficiency requires access to patients. So this backdrop, everything that we've described thus far, has really led us to the intervention that Dr. Lee and I lead as co-PI on the grant. The legislation has changed nationally, and in Maryland, the implications will impact patients, physicians, as well as advanced practice providers. So we recognize that the future workforce needs to be diverse, and it needs to include multiple providers providing care to individuals seeking care related to pregnancy. We aim through our grant to increase the diversity of the workforce, both racially and ethnically, by including PAs, NPs, and certified nurse midwives. We also intend to provide education in advanced contraception as well as abortion care. We also aim to meet those gap needs that we've identified through our state, where we know that 63% of our counties do not have access to abortion clinics. And so, as Jessica was saying, we intend to take a 2-prong approach. One is to upskill the current workforce. As Dr. Lee mentioned, many of our physicians practicing in emergency medicine, urgent care, pediatrics, OBGYN, primary care are interested in including abortion care in their provision of care. We also know that there are existing licensed and practicing physician assistants, nurse practitioners, and certified nurse midwives who are capable of providing this care with additional support. And then, as Dr. Lee mentioned, we have the next generation of care providers. We have a diverse group of students who are NPs, PAs, medical students, certified nurse midwives, who are interested in providing this care in Maryland and beyond. And fortunately, we are able to provide that education. Our strategy is, first of all, to raise awareness about the legislative change. As Dr. Lee mentioned, in 31 states in the US currently, there are restrictive practices related to the delivery of abortion care, which we feel is healthcare. We intend to train up the current workforce and primarily the ability of ultrasound services, medical abortion, making that more available, and then identify those who wish to include advanced skills, not only including advanced contraceptive methods, but also vacuum extraction abortion care. We also intend to expand the training to residents, medicine, medical students, PA, NP, and midwives who opt into training. We are not making this mandatory to our students. We are offering our students the ability to opt in. They will go through a very extensive didactic training, as well as simulation and clinical training. So the backbone of our training really leans into work that has been done at UCSF, which has published its 7th edition of the Teach Abortion Training Curriculum. Our experts have reviewed this curriculum, which was last published in June of 2022. And we've recognized that there's some Maryland-specific information that's required, and we are creating that material. So our students, both the current existing licensed providers as well as our students, will go through asynchronous training using Teach as well as a Maryland appendix. And then after that information has been completed, CME have been obtained, and or we have had them go through knowledge assessment. Then they'll move on to in-person simulation training. That in-person simulation training includes working with standardized patients related to counseling skills, patient-centric advising, as well as coaching and what to expect. Then they'll go on to ultrasound training. And then lastly, they will be exposed to procedural abortion training and contraceptive training. So to date, our progress, we received notice of the award late last year, and we've partnered with the Maryland Department of Health, the National Abortion Federation, and Planned Parenthood, as well as the area health education centers here in Maryland to help us execute this plan. We have completed, through the beneficial participation of a stakeholder group that helped us create a needs assessment survey, we have just deployed that to all individuals providing abortion care in the state to better understand their needs, barriers, and opportunities. We've completed the review of the TEACH curriculum by our expert interprofessional faculty team, and we are in the process of completing the Maryland content as well. We're in the process of doing a media awareness campaign, again, raising awareness about the legislation and garnering interest related to upcoming training. And the call of interest has been well received thus far. We are hearing from physicians, NPs, PAs, and certified nurse midwives across the state of their interest. And so our fellows application process and selection will soon be underway. Thank you for the opportunity to present, and I think I'm going to open it up to questions now.
Thank you, everyone. And I again want to thank everyone for popping comments and questions in both the chat box and the Q&A. You can keep them coming. I'll do my best to read them, but I'll kick off with some of the questions that are in there. Let me start with Haley, since she's probably thinks we forgot about her, but we didn't.
No.
So Haley, you talked about the states that have either licensure or certification or some kind of regulatory process for direct entry midwives. If a state does not have such provisions, does that mean people can, operate as direct entry midwives because there's no regulation?
So the full answer to that, I'm going to give the lawyerly answer here and say it depends.
It depends.
um,
Oh, you are ready to graduate.
yes, but I do have some specific examples to illustrate why the answer is it depends. So in some states, there is a law that says you're not allowed to practice medicine, and midwifery is included, right, in the definition of medicine, without some sort of certification or license. And in many of those states, it also says specifically that only certified nurse midwives are able to obtain a license to practice midwifery. Specifically, that seems to be true in Pennsylvania and Georgia. However, there are some states that kind of walk that back a little bit. So in Ohio, there is an exemption from that rule for freestanding birth centers. And they have some different requirements, but midwives and lay midwives are allowed, and direct entry midwives are allowed to practice in those birth centers. And then in Mississippi, it's interesting. Their statute defining the practice of medicine specifically excludes, and I'm going to quote the language directly, females engaged solely in the practice of midwifery. So they don't provide a license for direct entry midwives in Mississippi, but that language is included in the statute. So whatever that means, I don't know exactly, but females engaged solely in the practice of midwifery are specifically exempted by statute. So they are allowed to practice without a certification or license.
That's super interesting. I just want to say we did not queue that question up. That was a real question, and how
Yeah.
quickly Haley was able to find us very substantive answer. So let me switch over to Jordan. I'm kind of going to blend two questions here. One was about what methodology did you use to pull all of these laws, particularly the reimbursement stuff, which you and I know is the hardest part of this. So the question person knew that as well. And then if there were any kind of creative or unique provisions that you wanted to just give a shout out to.
Yeah, definitely. So, unfortunately, or fortunately, however you want to look at it, my research involved going through the individual administrative and statutory code for every single state and doing a search for the word doula and some other terms, because we knew maybe sometimes doula wouldn't be a key. And so, looking for some of the other words that are commonly associated with doula care and coverage, and then reading through all the statutes and regulations that mention doula, and kind of sorting through that and parsing through what was actually relevant to our work. So it's definitely a long process, but I think that it was really thorough. And again, we didn't focus on any informal agency documents or guidance. We only went through the actual statutory code and the regulatory code for the state. So if it wasn't included within those two sources, we didn't include it in our chart just for purposes of continuity. But I was able to find, there are some sorts of laws that are just done through informal agency guidance. For example, there was a county in Florida that has a virtual doula service program that they're trying out, but that's just one county in Florida. So that wasn't something that would be reflected in our chart. But that was necessarily the process. With the reimbursement rates specifically, there is a lot of times very vague discussion about what the reimbursement would look like. So we were able to determine whether or not the reimbursement rate exists from the statutory regulatory code, but actually figuring out that rate itself usually required going on Google, looking at the actual state's websites, the state materials that they've put out, and finding that. And that's why I highlighted Maryland and Minnesota specifically within my presentation, because they were the only two states, at least from my research, where I was able to find a codified rate that is passed into the text of the law itself, rather than directing you to an agency website or putting in a percentage of some other rate that maybe is put out by the federal government as a basis. So I think that that's something that if you are more interested in, I definitely find it very challenging to find. We can reach out. And then as far as any other unique policies I found, one that I thought was really inventive is in Illinois. They allow a doula to provide a basis for a reasonable accommodation in the workplace for a pregnant individual. So typically, if you're a pregnant individual and you maybe need some certain accommodation at work, that would be something you need a doctor's note for. But in Illinois, they're allowing doulas to be the one to provide that. So I think that opens up the possibility and comfortability for birthing individuals to be able to get the support they need. Another interesting one also out of Illinois is they have a home visiting program in which you can get a doula to come help after birth doing that light housekeeping that we were talking about. And they also provide that. So a lot of great stuff came out of Illinois specifically. So those are some, yeah.
Can't say how helpful light housekeeping would have been for my child. So Doctors Lee and Bonnie, I'm trying to blend together these two questions, so hopefully it makes sense. First, what are the risks of allowing essentially non-OBs, but NPs, PAs, GPs who haven't, gone through extensive obstetrics or, gynecological training to provide abortion care, but couple that a little bit with, because the opposite question was kind of like, well, why hasn't this always been the case? Why isn't this the way the world is? Why did it take legislation and funding and this new training program to get this to be the case?
Well, I think if you go to some other conferences around the country, specifically those geared towards APCs and midwives, historically, this has been the work of an APC or a midwife. It's the physicians that stole it from them, with modern medicine, right? And I can say that as a physician myself, like we really sequestered and siloed this care in a way that hasn't been fair. So that being said, it's always existed. And I think the legalization and the restriction about that, we're now reversing that. And I think we've known that because of the evidence, there are many studies showing safety is equivalent among an advanced practice clinician compared to a physician performing this care. There is no reason to restrict it. We're going to expand access, improve equity, if we can really act on these laws, uptrain the APC population, and really get abortion out to those who need it most in the rural and more disadvantaged parts of our country.
And just building off of what Dr. Lee said, our accreditation standards, knowing that there's so many physician-only states, did not require abortion care education, experience, and training for many PAs and NPs. And so one of the things that we did in preparation for our grant is we did a curricular audit across campus, which included the standards. And so what we understood was that everybody had the foundation, right? Everybody had the physical exam, the anatomy, the physiology, the advanced pharmacology, all of the pathophysiology, understanding pregnancy, et cetera. But what they lacked was many of the things that we're going to be providing in the simulation and through the teach in our appendix in Maryland, the deeper dive into abortion care. And so to Dr. Lee's point, we're providing that additional training to make sure that patient safety is first and is the greatest concern. And we know that the research shows that with that education and experience, outcomes are absolutely equivalent and complication rates are very, very, very low.
You're on mute.
Yep, I was. Thank you both so much. I appreciate your honesty, Dr. Lee, about how the doctors stole this away, because I don't know that sometimes that's acknowledged. I really appreciate that. I'm going to come back to Jordan Haley and then back again to the Maryland example with some more questions. So for you, Jordan, what you indicate, obviously the positive impacts of using doulas, and Haley told us about the racial disparity. I mean, we already have bad maternal health outcomes, but these are, even worse for Black families and other families of color. So is the doula workforce more diverse? Is that one of the reasons that the doula care has this impact?
Yeah, so essentially, I wouldn't say that the doula workforce is necessarily more diverse, but I think two important points are the doula workforce is increasingly becoming more diverse, and the community-based doula workforce, the community-based doula workforce is more diverse than I think we'd see in most traditional professions. And so there was a study done in 2021 in Washington State, and that study has been tracking the doula workforce within the state, and they're finding that the diversity is increasing within their doula workforce year by year, as well as the diversity of those who are accessing doula services. So that's definitely a positive change over time. And Washington is one of the states with the most comprehensive doula regulations and statutes in place. So we can see there that it is having an impact. And then in a study done in 2019 about the composition of the doula workforce of community-based doulas specifically, there is a much higher rate of racial and ethnic minority community-based doulas than there are white community-based doulas. And so I think within that subset specifically, you're seeing that there's more diverse care being provided.
So the easy transition is over to you, Haley. Essentially a similar question is the advantage of allowing direct entry midwives that you will expand the diversity of the workforce?
Yeah, I think that is certainly a potential advantage, right? Because not only would you be increasing the number of providers, but you're increasing the pathways to being able to provide that care. And so an increase in pathways and methods could lead to an increase in diversity and then hopefully decrease that disparity in maternal mortality rates.
And I think a related question, and I'll ask you, I don't know that you'll know the answer, and I only know because I did research while the question came in. But the question came because you mentioned about, I think, about there not being federal loans available for the education, and kind of why is that? And is there any kind of effort being undertaken to change that?
I don't know the answer to that. I didn't really look into that for my resource. So if you know the answer, feel free to
I mean, I'm going to say my quick lawyering would tell me, and I did put a link in the Q&A to the page for the National Association of Certified Professional Midwives, because they indicate that it is their top priority to expand access to federal loan funding for students who are seeking certification as midwives. And their page goes through some recent legislation that was passed that provided some resource in this space, and then other pending efforts that have been undertaken in Congress that have yet to succeed. I think the kind of the technical legal answer is that the entities through which the licensure is coming are not schools that are quote eligible for federal loans under the accreditation system of the Department of Education, and that is a prerequisite to a student receiving the federal financial aid. And so the pieces of legislation that seem to be out there are kind of finding separate avenues instead of using the Department of Education funding process, but separate avenues to make funds available. But I do encourage folks to look at the NACPM page, because it also does talk a bit about some advocacy that they're doing and how you can support that advocacy effort. So Drs. Lee and Bondi, there's a question here I have to read it a little more closely because I didn't know what the acronym stood for. But some of these questions are coming out of Texas, where we all know there is obviously a challenge, virtually no access to abortion care. But the question is for can the APAOG, which I did not hear of before, but it's the Association of PAs in Obstetrics and Gynecology, can they play a role in advocating in a particular state like Texas or Mississippi, where there is, very minimal legal access to abortion care, to expand access to reproductive health care in the ways that Maryland is doing? And kind of the other question that couples with that, that came into, what are the hurdles to getting something like Maryland's law adopted? What did we experience? I know we're in a, more liberal state in this regard, but what were the hurdles? What were the concerns and challenges expressed?
So I would absolutely encourage my colleagues in Texas and throughout the PA advocacy space, particularly those with, OBGYN, to advocate and work collaboratively with our physicians, nurse practitioners, and certified nurse midwives to expand access to reproductive health. I think that really played a significant role in the success of Maryland, that we were not coming to the legislature as separate entities, but rather as an interprofessional team advocating for individuals and Marylanders to have access to this care. And I think that appeal during testimony, which included physicians like Dr. Lee, as well as Dr. Lee works with a nurse practitioner who's also on our grant, who testified to really encourage this legislation to move forward. I think when you have multiple healthcare providers laser focused on an identified need and a public health issue, coming to your legislature and really appealing to them to improve equity of care and access to care, and showing them the data that we can really expand that based on the diversity in our different disciplines, makes a difference. Jessica, anything else to talk about with the hurdles?
No, I completely agree with MJ. I got the chance to advocate for this specific Abortion Care Access Act, both with my with our NP as well as with Maryland ACOG, which is our OBGYN society. But I would say, besides data, what really resonates with legislators are stories. So those who are listening, who are clinicians, who see the impact of abortion on both the positive impact, if they're an abortion protective state. Your legislators like to hear about your successes. Like, they defend reproductive rights. I mean, sadly, healthcare and policy are all mixed up in our country. But that being said, they want to hear that you appreciate them continuing to defend that. And if you're an abortion restrictive state, they want to hear the negative repercussions. And so often it's very few who speak out, and I don't envy those in Texas who may fear for their licenses or their lives. But I will also speak to the many lawyers on this call. Try to have their back. Like, a lot of times physicians on these borderline calls, someone's miscarrying, there's still a fetal heart rate. They don't feel like they have the backing of their hospital legal team to do something. When really it should be, we got you, do what you need to save the patient's life. We'll work out the legal issues later. And I'm so sad to hear that, like, that is not the support that all the clinicians have. Lawyers probably don't even feel supported to do that kind of work. And I really hope we together, especially given the setting that we're talking about, can further access and support for reproductive ideal care.
Jessica also opened up another thing that I think is important to talk about, and that is the fact that in Maryland, in addition to changing the law from a physician-only state to include APCs in delivering the care, there was other legislation that was also passed, and that is, we have shield laws in Maryland to protect providers in Maryland who are providing this care to out-of-state individuals, to people within state. We also have privacy and protection laws in place to protect patients related to those that seek this care within the state. And so I think that there's a basket of legislation that needs to be considered to create the environment to be able to make it safe for Jessica and myself and our colleagues to do this work and to talk about this work. And we often say how lucky we feel that we are here and able to be able to move this forward, this legislation forward, and this innovative project.
I mean, and it's fair to say also, I mean, even for us in Maryland, we had a hurdle in getting the funding, although the legislation passed, our governor at that time withheld the funding for the program. So it was a law, but it couldn't be implemented without that funding. So we do even experience that, here in Maryland. I want to say if it would be helpful for folks to listen to the hearings from the when the legislation was passed, just shoot me an email after this and I can send you the links. So you could listen to the hearings in the House and in the Senate in Maryland and get an understanding of, what the affirmative testimony that we heard about here, but what the questions were like from the members, who else testified on the legislation, because that could help you understand maybe how to craft your law for your state that might look a little different than Maryland's, because some of the questions that might come your way. So I, totally encourage that. And I want to, acknowledge Dr. Lee's comment about lawyers. I think, lawyers are almost by nature taught to be, unfortunately, in law school, incredibly risk averse for our clients. And so we often are considered the house of no, right? So, the easier answer is to say no. But in this circumstance, I think a lot of we don't have, I think, sufficient systems for educating lawyers in this space. And so you just made me think about that's a gap that we need to fill in our own education and training, both for new lawyers, but even more importantly right now for existing lawyers, to make sure that they're understanding, the state laws and kind of the ramifications of a yes and a no in particular circumstances. Not that they have to be the medical professional, that's not their job, but to work, collaboratively before problems arise, so that when they do, there is already that built understanding, respect, et cetera, between the medical professional and the lawyer. So I completely appreciate that, that shout out. I'm gonna ask one last question because it is the question, and then see if anybody has any wrap up comments that they want to make before I let Daniel close it out with his technical answers. And that was, the provider rate in Canada looks to be about the same as the provider rate in the United States, but the maternal mortality rate in Canada is much lower. The US is about 4 times higher. Any thoughts on why that is? So that is the question. So anything that you want to close out with on that comment, have the floor, each of you, in whatever order you prefer. I will call on you because I am a law professor, but don't make me.
Well, I mean, I provided that statistic, so I guess I will get started with my answer. And I think that probably a large part of it has to do with, at least in terms of disparities, right, the way we provide care, and implicit biases, systemic racism, and those kinds of things that are present in our larger society and in the medical field as well. And I think that has to explain at least part of it.
Yeah, I'll agree with what Haley had to say. Actually, I have a friend from the United Kingdom. She grew up in America and she's now living there. And it's just learning about all the access they have without burden is quite shocking. She can get free STD tests in the mail, free IUDs with an appointment with no questions asked, access to midwives, more maternity and paternity care. I think when you're looking, I know the UK is not Canada, but I think when you're looking at the access of even just the services available more widely in a lot of these countries, and they're continually expanding, whereas in America or in the United States, we're seeing ourselves restrict the access of services and what we have available. I think that that's probably what it's coming down to in a lot of ways.
And I forget the breakdown of midwives to physicians between Canada and us, but I think they allow their midwives to do more. Their OB/GYN residency the extra year beyond ours, so the OB physicians usually are much more specialized. So I think we're talking about a way of really getting more primary care options out to people who need reproductive health care. Maybe a more dispersed workforce is another hypothesis I would have. But I do know for a fact that when Canada rolled out medication abortion, they rolled it out better than we did. Was it 2 decades later? People don't realize that Canada did not have mifepristone until very recently, but they made it available in pharmacies. They made it available without having to hand the pill to my patient and watch them swallow it, which was the rule in America for so long. And so the legislation around that really improved access to MedAV.
Yeah. Well, I think my colleagues have really answered this question and thoughtfully. So I think that any way that we can promote health equity, improve access, will definitely improve, hopefully, those outcomes and get us maybe closer to what we see in Canada. We know that there are disparities here, and it is our responsibility to work toward improving that and improving health equity. I also would say that, Jessica and I talk about this, that for some individuals, pregnancy can be dangerous because of prior illness, prior complicated comorbidities. And so pregnancy itself can be dangerous for folks. And that's why having the ability to receive the services that we're talking about for reproductive health, both contraceptive services, but abortion services, are so critical as we look at health disparities.
Thank you. And I agree with all of that, but it wouldn't be a public health meeting if we didn't say also we have to look at other social determinants of health that vary across the countries that also contribute to maternal mortality. Something as simple as paid leave for parents and the like. So, but on that note, we are done. And Daniel, I think you just have a wrap up comment. And I want to thank the panelists, but also the participants attendees, because they're what makes it really fun at the end.
Yeah, I just wanted to give a thanks to all the speakers today, as well as Kathy for being the moderator. I just want to remind everyone that you will be receiving a copy of the slides as well as a recording of the webinar in about a week. You'll be getting that directly emailed to you with the links to that on the network's website. So please be on the lookout for that. And with that, I hope you all have a nice afternoon. Thank you.